In the GI fields, there has been a lot of breakthroughs that unfortunately was somewhat disappointing. I think the main thing is with immunotherapy that has some of the data that was immunotherapy that has been presented in upper GI and in hepatocellular carcinoma, where at the beginning there was some robust data on getting those drugs approved in a single arm study. But when they started to do a randomized study, whether in first line or in second line, those trials has been mostly negative, at least from the primary endpoint. But it is clear that even though the trials, even though, for example, the first line trial in the Keynote study, where they compared pembro versus chemo alone, or there was the second part where it was a non-inferiority study where they compared chemo versus pembrolizumab. Even though the chemo plus pembro was no better than chemo alone, it did show that pembrolizumab was non-inferior to chemo alone with better toxicity profile. And in the trials in ATC, the second line study, which was presented comparing pembrolizumab versus best supportive care, quite did not meet the endpoint. But consistent with other studies, there is a subset of population that definitely do benefit from immunotherapy, except we just need to get a better biomarker to select which patients benefit from immunotherapy.